Evening, everyone. Welcome to today's webinar hosted through the International Society for Minimally Invasive Cardiothoracic Surgery. It's my great pleasure to moderate this session along with Dr. Dolly for the session on behalf of the Enhanced Recovery After Cardiac Surgery Society. The ERAS Cardiac Surgery Society is dedicated to advancing perioperative care for the cardiac surgery patient by fostering collaborative research, education, and dissemination of best evidence practices that improves recovery, reduces complications, and enhances value in clinical care. Today's discussion brings together experts to explore how ERAS pathways can elevate outcomes of minimally invasive cardiac surgery with practical insights for teams striving to integrate these approaches into clinical practice. So with that, let me turn over to our co-moderator and lead from the ISMIC Society, Dr. Dal.
Thank you very much, Dr. Rakesh, and I'm thrilled to have this collaboration with ERAS because I think ISMIC's International Society for Minimally Invasive Cardiac Surgery, it's crucial to have good results also with the postoperative and preoperative and intraoperative care. So I think this collaboration will be very fruitful, and especially for the patients. And therefore, I I'm thrilled to have all these kind of good speakers, and also the president of ERAS to do a talk, and the past president of ISMICS. So with that, I hand over to Dr. Rakesh again to introduce the first speaker.
Fantastic. We will have 4 talks today, which we'll go through them in sequence and then have an opportunity for panel discussion at the end. Please put your comments and questions in the Q&A tab, not the chat tab, but the Q&A tab. We'll do our best to answer them either live during the session or by typing in our responses in the chat box there as well. We'll get to as many as we can through the course of this next hour. So with that, let's kick things off. Our first speaker is Dr. Dan Engelman, Professor of Surgery and Healthcare Delivery and Population Sciences at UMass Medical School in Bay State. He's also the president of the ERAS Cardiac Surgery Society and the medical director of the Cardiac Surgery Critical Care at Bay State Health. His topic will be philosophy of preparedness, translating ERAS principles to the minimally invasive operating room. Dan, please take it away.
Good morning, everyone. Thank you. Thanks for that nice introduction. These are my disclosures, which are not relevant to this particular talk. So we've briefly gone over what ERAS is, but it's a perioperative care model standardizing evidence-based best practice. Nothing we discuss hasn't been evidence-based. Sure, there are different levels of evidence behind the recommendations, but everything's based on literature. And their goal is to optimize preoperative condition, minimize surgical and psychological trauma, and promote early complete recovery. For most surgical specialties, and this is important, minimally invasive surgery is considered a critical aspect of a comprehensive ERAS program. I'm talking about every other surgical subspecialty, and it's in their consensus work and guidelines. And the point is to reduce tissue destruction, reduce pain, and hasten recovery. However, in cardiac surgery, those have not yet made it to the level of our guidelines. And I think this would be a good topic to discuss during our discussion at the end of this webinar. So why is ERAS important? It turns out you can do a perfect operation and still have tremendous morbidity and mortality. And this key manuscript published way back in 2012 pointed out that 81% of preventable mortality following open cardiac surgery was due to an inadequately prepared patient or due to something that happened outside of the operating room post-operatively. So there's a lot of room, a lot of wiggle room to get these patients to recover better and quicker and safer that's outside of the operating room. So our most recent updated consensus work was published only in mid-2024. It was published in the Annals. This is the reference, but it went over all the different components, and we're going to briefly discuss those. But here's sort of an overview. Everybody knows that cardiac surgery knocks you back. You take a hit when you have cardiac surgery. And then you start to slowly recover and you go to a new baseline. The goal of enhanced recovery is when you have that hit, you're already above where you could have been through adequate and essential pre-operative optimization. So that when you take that operative hit, it still keeps you above where you otherwise would be. And then you have that postoperative phase of enhanced recovery, and hopefully you get to a new baseline, which is better than where you started. That's the whole point of this cardiac surgery. We don't want to be worse than we started or even where we started. We want to be better, and that's what patients want. So here's some brief overviews of literature that's come out. I mean, the first question people ask is, well, should we do on-table extubation? And in this study that was recently published in 24, they said, well, on-table extubation in patients who had mitral valve surgery through a transaxillary minimally invasive approach had decreased ICU stay and decreased hospitalization. So that sounds promising. I'd say in that particular approach, minimally invasive over the 5-year period, on-table extubation appeared to be good. Well, do we even have to go to the ICU? Here's another study that came out last year also, and that showed that outcomes after minimally invasive mitral surgery for primary severe mitral regurgitation, they compared standard of care to no ICU, go from the operating room to sort of a higher level of recovery slash room where they could recover. And what was the result? The patients had actually less pain than you would expect. They had certainly less ventilation time, no mortalities in either group, and their hospitalization was cut down by 1 day. So, well, that seems nice if you may not need an ICU following minimally invasive surgical approaches. But really, this is the overwhelming summary of what ERAS is when it comes to surgery. And there's multiple components. We're not going to go through each of them, but pre-operatively, you need to optimize these patients. Here are all the things you can do before surgery to get your patient ready for cardiac surgery. In the operating room, there are ERAS components. The anesthesiologist, the multidisciplinary team needs to work with you to make sure that all this is going on while you're doing your operation, be it open sternotomy or minimally invasive. Post-operatively, that's where we really kick into gear. All of these little components are cumulative. They each have an aggregation of marginal gain. Small little incremental increases will overall really improve the speed and the depth of recovery. And finally, I can't help but talk about how you need to involve not just the surgeon, not just the anesthesiologist, but perfusion, nursing, your advanced practice providers, cardiac rehab. Pharmacist needs to be there right on top of it, nutrition services, etc. It's a multidisciplinary game. In summary, although ERAS can be implemented without minimally invasive surgery, a comprehensive mixed program will not be effective without ERAS, minimizing the non-surgical invasiveness of the surgical process. I want to thank you for this invitation to speak.
Thank you, Dan. Excellent starting point. I'll get Dr. Daly to introduce our next speaker.
Yes, the next speaker is very important. It's in this topic. It's Dr. Niv Ad. He is a professor of surgery. He is the past president of ISMIX, and he is now the editor of Innovation. And he had a very good, was in a very good review that was called Maximizing Minimally Invasive Surgery in ERAS. So please, Dr. Ad, please tell us about integrating ERAS with minimally invasive surgery.
Okay, good. Thank you, Gray, for the kind introduction. And obviously, you'll hear a lot of repetitions today, but the main point I think that Dan brought over is that a successful minimally invasive program is dependent on collaboration and really focus on preoperative optimization and postoperative pathways. These are my disclosure. None is related to this talk. So I'm talking 20 years ago now, almost. September 2006, when I joined the previous group I was running, the first thing we started is we established a real multidisciplinary team that included physicians, a surgeon, anesthesia, intensivists, nursing, from all aspects of the service line, physician assistants, and nurse practitioners, perfusion team, physical therapists, and database analysts, because data is really important to understand what we do. And basically, that multidisciplinary team was not just on paper. had monthly meetings and review of the data, review and assessment of clinical and administrative pathways, and basically action items. So we had, like they have in any management team in the hospital, we had goals for the quarter, goals for the year, threshold to meet, and so on and so forth. Each member of the team had an equal voice, and there was no veto power to any of the members of the team. So basically, it was a kind of a multidisciplinary, all-in, way ahead of its time, and we are very proud of it. And we saw the results, on many aspects of what we do almost immediately. So basically, that's how we built it, a multidisciplinary team to do all the things I just mentioned. Patient optimization with issues of, anemia, fluid overload, amiodarone for perioperative AF, pulmonary system to maximize, breathing, imaging to be able to plan the surgery better. Surgical excellence is the key of ERAS. Without surgical excellence, you can't have ERAS. So I agree with Dan that a lot of things are happening outside the OR, but usually the jump start for any successful postoperative pathway is excellent surgery. And I really, from the very beginning, stress the issue of no bleeding. Bleeding is the main culprit for ERAS, for patient recovery in general, and we lowered our postoperative bleeding and take back to numbers that are really almost neglectable. Early extubation, regional blocks, early mobilizations, all of those are basically between anesthesia, surgeons, and obviously in the ICU. Those are all very, very important. We found very early on that on-table extubation is not really working well with our very busy program, but early extubation is, and I will share some numbers with you. And we started a program that it's kind of a predecessor to the ERAS. It's called RABIT, Rapid After Bypass Being Telemetry. And I'll show you how we did all that. So let's say just one example of blood utilization initiative. We were very concerned when a protein became an issue with labeling and so on in the US, and we gathered the team together and we basically put together a multidisciplinary team from all aspects of what I shared with you earlier, and started education, research, coordination. And we don't have enough time to go, but I think here is what you get when you work together. We went from really high percent of patients getting any blood product in 2005-06 to about 1/4 of the patient only getting blood either intraoperatively or postoperatively. And I can tell you, and Ron is seeing the numbers on our regional collaboration, the numbers are even lower today. But look how much of a drop we have with the same team, with the same surgeons, just by coordinating, understanding the data, and starting really focusing on blood utilization and blood products. So that's one example how a team can work together to optimize things. What is RABIT? Rapid After Bypass Being Telemetry. It's the patient being screened preoperatively, EF over 35, fairly low, no renal issues, and other factors like weight and other mobility issues that we have to really take into consideration. Anesthesia is done appropriately. We don't want to extubate the patient on the table, but we want to extubate them quick enough in the ICU, because the definition of rapid is being out of the ICU within 6 hours. Within 6 hours, the patient are out of the ICU. ICU, no bleeding, no vent issues, you progress, and then you step down to a unit with a nursing ratio of 4:1, but only for the rapid patient. So it's kind of misleading. You don't have to have all your step-down unit with 4-to-1 ratio. But if you have 4 patients that day, or in our case a little more, but let's say 4 patients that day, only those patients needs 1 nurse if all of them are getting to the ICU. Now, the cost savings are immense. We don't have time to talk about it, but patients are leaving the ICU before midnight, meaning the ICU personnel is going to be adjusted accordingly. So it is a very high rate in our minimally invasive program, over 80%. The majority of the patients are mitral valve repair, obviously, and mitral valve repair patients being discharged from the hospital day 1 or 2, the majority of them. For the general practice, over 50% were rabbit patients. Obviously, no MCS, transplant, type A dissection and emergency cases. I just want to reiterate it. I mean, it's more to the elective or the what I call the mild urgent patients, but some of the urgent patients are still getting qualified. And here are some numbers how in a multidisciplinary way and good judgment you can get a group of patients with a mean ERAS score of 7 to have intubation time of 3.4 hours in average, 30 days operative mortality of 0.25%, hospital stay of 4 days, readmission rate of 6.3%, and new onset atrial fibrillation of 7.6%. This is just a taste of what can be achieved with a good functional team. Now, the key is not just to meet and decide on protocols. The key is to meet and monitor the implications and actually the performance of those protocols, and go by operator to operator and see their performance over the time and see how well they do within the goals that we put to ourselves to get. So it's coordination, optimization preoperatively, and I believe Ron is going to share with us a little bit. The clinical concept of rabbit utilizes a very simple algorithm that can easily apply to any program in the world. And the rabbit program proved to be an excellent predictor for good outcome, shorter ICU, shorter hospital stay, and lower cost. Thank you. Oh, one more thing I want to say. I want to emphasize that I'm really am concerned about this misconception, misperception, and really what's really spreading out there on the use of the heart-lung machine. And we lately published this expert opinion in JTCVS, Mind over Heart, is cognitive decline after cardiac surgery real? And I think that all the patients, all the results you saw are for patients that were operated on pump. And the overuse of the term cognitive dysfunction and pump head and all those other things that are not based on the evidence should be reassessed. And I urge you to read this expert opinion, not because we wrote it, but because it's a fair analysis of the current evidence, which is very poor to support cognitive decline during heart surgery. And with that, I'm done. Thank you.
That's fantastic. Thank you, Niv. Really
Thank
great talk.
Thank you so much, Janet. It was very nice overview, and we will discuss in the end. And now I hand over to Rakesh again.
Thank you very much. So just a reminder for our participants in the webinar, please put your questions in the Q&A tab of your toolbar, either the bottom or the top of your screen. We'll do our best to get to all of them before the end of the hour. We have a few trickling in now, so please put those in there. Our next speaker is a great pleasure to introduce Dr. Ron Salinger. He's an associate professor of surgery at the University of Maryland Medical School of Medicine, the vice president of education for the ERAS Cardiac Surgery Society, and chief of cardiac surgery at the University of Maryland Medical Center. His title of his talk and the content will be on data-driven recovery, measuring value and outcomes in ERAS-enabled minimally invasive cardiac surgery. Dr. Salinger.
Thank you, Rakesh. Thanks for inviting me to be a part of this collaboration, and thank you for everybody who's tuning in for listening. I'm going to talk about the intersection of minimally invasive cardiac surgery and enhanced recovery and ERAS enabled minimally invasive cardiac surgery, basically asking the question, what, if anything, does ERAS add on top of the benefits that patients already receive from minimally invasive surgery? These are my disclosures. So Dr. Engelman did a very nice job of giving us an overview of the benefits we see with ERAS, and Dr. Ad did a nice job of adding some specific results from his experience. And these are just kind of the way I look at the general cycle of the ERAS benefits. So you start by doing a very good job of preparing your patient for the operating room. Then you use less opioids. You push early extubation, early mobilization, and you get the benefits of reduced complications, reduced length of stay, and a faster overall recovery. Turns out minimally invasive cardiac surgery has some very similar demonstrated benefits. You start out with less surgical trauma and high quality surgery, and you reap the benefits of reduced transfusions, earlier extubation, reduced length of stay, and a faster return to moderate or greater levels of activity during the recovery period. So the question that a lot of groups have asked is, what happens if you take a group of minimally invasive cardiac surgery patients and then add an ERAS platform into their care? Do you get additional benefit? And there turns out there's a fair number of studies looking at this. This group from France looked at a group of TCAB patients taken care of with conventional perioperative care versus an enhanced recovery program. I'm just going to go over a few of these studies. This is the same group from France looking at minimally invasive aortic valve replacements, conventional perioperative care versus ERAS care. And then the group from Hamburg, which has published this study looking at in a very established minimally invasive valve program, adding an ERAS program. And this group has published a lot on this topic, including the potential economic benefits and savings. And then there's also this review from a group in Alessandria, Italy, looking at this exact question, which is a good review. And they all had concordant findings. And the most fundamental finding that we shouldn't lose sight of is that this is safe. There was no excess complications or mortality from pushing patients to recover more quickly, which may sound obvious to a lot of people listening, but if you think about colleagues that are reluctant to extubate earlier or mobilize earlier or discharge people earlier or discharge them home instead of a facility, many times they have essentially a safety concern because they think moving slower is safer. But none of these studies showed that. And then on top of that, they found that enhanced recovery added, in addition to the benefits the patients were already seeing from minimally invasive surgery, added additional decreases in ventilation time, even less transfusions, and a lower length of stay. So when we think about how minimally invasive cardiac surgery fits into the cycle of ERAS benefits, we think really minimally invasive surgery complements ERAS, and ERAS complements minimally invasive surgery, and it aligns with the other elements of ERAS care. So now you can think of taking a very well-prepared patient, doing high-quality surgery with less surgical trauma, and then doing all the other ERAS things and having even more benefits of decreased complications and a quicker recovery. And for those people who may be asking or wondering how to start an ERAS program, the ERAS Cardiac Society published a template of how to build a program in 2020 in seminars, and this is the summary slide. Basically, high overview, you do a current state analysis of your program, where the gaps in care may exist. You create a core team that's interested in really changing things. You educate that core team on enhanced recovery, and then that core team educates the larger program. You develop protocols. You don't have to develop them all at once, and you implement them. And then very importantly, you have to audit your outcomes, and you have to solicit honest feedback from everyone in the larger program, particularly the people that are skeptics. And then for protocols that aren't working or aren't user-friendly, you have to change those. And for ones that are working, you have to think of ways to make them better. And in that way, evolve your program to get even more benefit for patients. About a year ago, the ERAS Cardiac Society, in collaboration with a number of minimally invasive cardiac surgery experts, published a paper trying to define and ask the question, what is complete minimally invasive cardiac surgery? What are the elements of a comprehensive minimally invasive approach? And we came up with 3 things that comprise minimally invasive surgery. And our proposal is that, of course, number 1, you need to have a smaller and alternative incision to a full sternotomy. Number 2, you have to have a good plan for myocardial preservation. And that can vary. That can be cardioplegic arrest, that could be fibrillatory surgery, that could be off-pump surgery. And number 3, and we think this is critical for a complete minimally invasive approach, you have to have an aggressive, standardized, perioperative enhanced recovery approach. So that way, your patients can fully realize the benefits of the minimally invasive surgery that they're having and recover as quickly as possible. And then we think that if you have that perioperative standardized care, then you're not creating any barriers to how quickly they can recover. You can let them recover as quickly as possible. And the minimally invasive patients are primed, as we know, to recover very quickly. And then I just have this short video of kind of what minimally invasive cardiac surgery and enhanced recovery can do together. And I think of it as enhanced recovery just allowing the minimally invasive patients to reach their full potential. This is a patient who's post-op day 2 from a mini right thoracotomy mitral repair.
Hi, everybody. I'm here with Donald Matz, post-op day 2 from a minimally invasive mitral repair. And we're just going to chat with him a little bit, see how he's doing. Mr. Matz, how are you feeling?
I feel great. A little bit of pain from incisions and whatnot, but other than that, no problems.
Great, you hear that? 0 pain, he said. No pain.
Not quite no pain, but with the painkillers, it's no pain.
How are you moving around?
Good.
Yeah.
Yeah, they had me
You
up
able to walk?
walking today. They had me up and down a flight of stairs.
How's your breathing feel?
Not bad. A little shallower than usual, but it's staying up there. So
Can you, are you restricted in your movement? Can you move your arms and stuff?
yeah, I can do pretty much everything. It's a
Let's
little
hold
tight.
both your arms above your head for me.
This one's a little tight because of where the bandages are, but other than that,
Great.
no problem with my arms, no problem with my legs.
How would you say the surgery was compared to how you thought it was going to be?
I was shocked. I expected a lot more pain. I expected, I was shocked when they told me I could go home on the second day after surgery.
Okay, that's it. Thank you.
Fantastic, Ron. Thank you very much. A nice little snippet. It's always nice to have a story to go with the concepts we're discussing here. So thank you very much for that. We're going to switch gears a little bit to the other side of the thorax, and I'll have Dr. Gala introduce our next speaker.
Yes, I'm thrilled to introduce Chris Fernando, Director of Thoracic Surgery in Allegheny General Hospital, Pittsburgh. And he will tell us about implementing ERAS with ambulatory after thoracic surgery. So thank you.
Okay.
Please.
Thank you very much for the introduction and invitation. I'm going to be discussing ERAS, focusing on general thoracic surgery, a little bit on ambulation and also about lobectomy, and esophagectomy. So we've talked about how there's several strategies to ERAS, and early ambulation is really a key component of this, plus all the other things we've been talking about. And there are elements in the preoperative phase, intraoperative phase, and postoperative phases. And this requires changing institutional culture and also questioning surgical dogma. So what do I mean by dogma? An example is chest tubes. If you go and survey your colleagues, do you use suction? Do you use water seal? Do you use one chest tube? Do you use two chest tubes? What volume of drainage would you...
Dr. Fernando, I'm so sorry to interrupt. We don't see your slides right now.
Oh, you don't? Oh, excuse me. Let's have a look here. Let's have a look. Hey. Can you see it now?
We can see, yeah. That's okay. If we put a presenter view, we're all set. Perfect.
Okay. All
Perfect.
right.
Thank you.
So sorry about that. I got to this point. I talked about chest tubes, and we talked about the different strategies such as water seal versus suction, one versus two chest tubes, and also the minimal drainage volume that people would be comfortable with. And these are things that if you're part of a big group of surgeons, there'll be a little bit of voodoo that the different surgeons would follow with this. So the ERAS Society and European Society of Thoracic Surgeons addressed a lot of the ERAS items that were being looked at. And they looked at 45 different ERAS items from presentation through to postoperative discharge. And they went ahead and graded the evidence and gave best recommendations for what was out there at that time. And I wanted to point out that paper to you. So this was our experience. And as I mentioned, ambulation, I think, is a key part of ERAS, as well as minimally invasive surgery on its own. And this was from my previous institution. And one of the advantages we had over there was that we had a CVI tower with a dedicated cardiothoracic operating room, a recovery room that was only for cardiothoracic patients. And then the floor or step-down unit was on the same floor as the recovery room. So we had the ability to allow patients to walk from the recovery room to the step-down unit after they recovered from anesthesia. And so the program had been developed over a 6-year period, and I give some kudos to my associate, Dr. Kanda. And by the time we published this, we had about 1,000 patients that had undergone the ERAS program. And the initial paper that I'm going to be reviewing here looked at ERAS and VATS lobectomy specifically. And we had 304 patients in that series. So this was the ERAS protocol. And just much like in the other talks, you have the preoperative components, intraoperative, what happens in the recovery room, and then once you get to the floor or step-down unit. But if we focus on the ambulation component of that, we would encourage patients to walk about 20 minutes 3 times a day prior to surgery. When they got to the hospital, they would be placed in a chair rather than into a stretcher. And then we would have the patient walk from the pre-op area to the operating room. And then they would undergo their surgery. And then as soon as we have the patients extubated, and they were extubated in the operating room, the goal was to have the patients walk at least 250 feet in the first hour, and then to then walk from the recovery room to the bed in the step-down unit, which is about a 500-foot walk. And then once arriving in the step-down unit, the goal was then to have the patient walk at least 10 laps on the first day or day 0. And then on each consecutive day, have a goal of about 20 laps that we would try and have the patients walk. And we'd mark this on the patient's chalkboard so that the patients could see what progress they were making. Early ambulation is not a new concept. In fact, it was first proposed in 1949 by Lighthouser. And other investigators in thoracic surgery have also looked at early ambulation as a key component of their postoperative recovery protocols. This was a patient of mine, an 82-year-old person who had emphysema. He was felt not to be a candidate for a lobectomy, so he underwent a VATS segmentectomy. And here you can see him walking from the PACU to his hospital room shortly after surgery. And this was a patient on the first postoperative day after a VATS lobectomy. You can see he's been in the recliner where he actually spent most of the evening, and his wife was sleeping in the bed next to him when we made rounds in the morning. So in our first manuscript, what we wanted to show was that our primary aim was ambulation of at least 250 feet in the first hour after extubation. And then the secondary goals were any ambulation distance within 1 or 2 hours after extubation. We compared our early to late ERAS experience to assess a learning curve. And we also compared ERAS outcomes in the 304 lobectomy patients to 100 VATS lobectomy patients who did not undergo ERAS. So in terms of the primary aim, 250 feet achieved in 1 hour, 61% of patients achieved this. There was a learning curve effect of increasing from 37% in the early part of the series to 72% later on in the series. Any distance in 1 hour was achieved in 68.4% of patients, and again, a learning curve effect of 39% to about 81%, and any distance in 2 hours was achieved in about 94% of patients, again with a learning curve effect of 85% earlier to 97% later in the series. We had 3 patients who were unable to walk because of hypertension, and the mean time to ambulation after extubation was 57 minutes, and the range was 80 minutes earlier on to 46 minutes later in the series. So comparing the pre-ERAS to ERAS for VATS lobectomy, we achieved postoperative day 1 day discharge in 75% of patients when the ERAS protocol was implemented, compared to 25% before ERAS was implemented. The pneumonia incidence significantly decreased and was 6% in the pre-ERAS group and went down to 0.7% when ERAS was applied. So what about esophagectomy? This is a much more complex operation. It involves components in the abdomen, the chest, and often in the neck. And it's a highly morbid operation. And many series have shown grade 3 or higher adverse events occurring between 37 to 49%, and grade 3 pulmonary adverse events occurring between 12 to 18%. So other folks have looked at minimally invasive esophagectomy and ERAS, and this was a meta-analysis published last year. And the meta-analysis only include randomized trials, and there was 6 that were included. And you'll see that overall adverse event rates are decreased when you use ERAS, and pulmonary adverse events are also decreased when you use ERAS. In our own series, which we presented at ISMIX a few years ago, we also included an early ambulation protocol, but this was less intense because of the severity of the surgery. But we still encouraged ambulation in preoperatively and postoperatively. We had 30 patients, 28 who had a minimally invasive esophagectomy, and 2 who had an open or transhiatal esophagectomy. And 83.3% actually ambulated on postoperative day 0. 36.7% ambulated in the recovery room, and 90% of patients were able to ambulate by postoperative day 1. And this translated into a 20% grade 3 adverse event rate overall, and no mortalities, and only 1 grade 3 pulmonary adverse event of 3.3%. This was one of the patients after an open esophagectomy, and you can see him walking with the aid of 2 nurses to help him, but still walking shortly after extubation in the recovery room. I'm going to stop and say here that I think that minimally invasive surgery is key to ERAS and all the other things, but ambulation, I think, also is an important component. It's feasible after lung resection, and it's also feasible after esophagectomy. The implementation of ERAS is challenging, and that's been addressed earlier on. It's institution dependent But it's worth the effort because you will see dividends if you try and push this in your own program. And so I'll stop there and thank you very much again. And apologies for the mistakes with the slides earlier on.
Thank you very much for this great talk. And we know that we now see that if we have even smaller incisions, we have to have ERAS implemented. It's essential. We will now continue discussion, and we have some questions also in the Q&A. And I
Yes.
see that Dr. Aurora has the answer to some of them.
I do, yes. So I'm realizing we were so excited to get to these fantastic talks, and thank you to all of our speakers for keeping on time, being concise, but at the same time being very poignant with the points that you've brought forward that we can now dive into a little deeper with a good bit of time for some panel discussion. Dr. Dahl and I have introduced ourselves. We got to you guys before ourselves. So I'm Rakesh Arora. I'm a cardiac surgeon, intensivist, professor of surgery and anesthesiology at the Northwestern University Feinberg School of Medicine and the director of the CTICU. Dr. Dahle?
Yes, I'm a cardiothoracic surgeon from Oslo, Norway, and I'm currently the ISMICS president. I'm so thrilled to have all of you with me and to discuss this ERAS because it's the first time we have ERAS in the program for the ISMICS meeting that will be in Miami, and we even have we'll have poster session, and we have also had invited people to send abstracts on the ERAS. So I hope all of you will be there.
Yes, and we have one more gentleman joining us from the panel there, Dr. Abbas. Dr. Dahle, do you want to introduce Dr. Abbas?
Yes, Dr. Abbas, you can introduce yourself. He is the treasurer of ISMICS, and he is a thoracic surgeon, and we are thrilled to have you with us. Do you want to say to introduce yourself, Dr. Abbas?
Thank you, Dr. Dahle. It's a pleasure to be here. Thank you so much for the invitation. And I find this webinar really exciting for the benefit it provides us, but also to bring together the two columns of cardiothoracic surgery.
Great stuff. So we have some great questions coming in, but let me start with some general ones for our panelists first. So Dr. Engelman, Dan, let's start with you. So we think about ERAS cardiac surgery. We were somewhat ahead of the game in the mid 90s with early extubation and fast track anesthesia. And then there was a real lull until really 2019, but other surgical specialties had really embraced these concepts of ERAS. Tell us a little bit, why do you think we had this sort of lull and what's been the major factors to rejuvenate ERAS in both cardiac and thoracic surgery in the last 5 to 7 years?
Great question. I think some of it goes back to what Dr. Nivad was pointing out, and it's that you need perfection in surgery, and I think we are close to attaining that. Surgeons have gotten so good that we kind of peaked. We're at the 90th percentile operatively, and we neglected the preoperative and postoperative phases, and that's where there's the most meat left on the bone for improvement. That's my first thought. But if your question is why are we so far behind all the other surgical subspecialties, I think it's the perception that cardiac surgery is too complicated. Cardiopulmonary bypass, we have no eyes and nose. You have no idea how much blood you lose at the time of surgery. It's too, quote, complicated to do ERAS, which is a oversimplification. And I think that's where we kind of took our eye off the goal here. Others?
Yeah. Anyone else have comments on that?
Yeah. Oh, sorry. Go ahead.
Go ahead, Niv.
Well, I just want to say that we are also excited to all of the new technologies. So we sometimes forget the perioperative care of the patient, and that is the same as in the catheter treatment. And we even started to publish articles on that, how to treat the patient pre and post also catheter treatment. I think it's very important to focus on it. And yeah, Niv, you are the specialist in minimally invasive, so you know everything about that.
I was learning. I don't know everything about it, but I think to go back to what Dan is saying, and Dan was basically a world leader that we always listen to what he has to say. And so he has to be a little bit more politician. So I'll say things that I think I can push it as a non-official, with no official titles in the ERAS organization. I think people take it lightly. And what does it mean, take it lightly? Are there any difference in mental competency, resources, surgical skills between surgeons doing it or not? No, I don't think so. But I think that there are things that as surgeons, as leader surgeon in the institution, we don't want to actually get our hands into. And ERAS is an absolute a present for all of us, because that's one of the ways that we can treat our patients better. But we need to treat it as an administrative task. You can't just say, okay, we do ERAS and don't follow up. You can't say you do ERAS and you don't have the goals and the dashboards and so on and so forth. You have to monitor your performance like anything else you do. So multidisciplinary team, a lot of people are using it, but they are not really implementing it. Is it really multidisciplinary? Are you really working towards the same goals? And you have to refine those goals, like with our blood transfusion protocol, for instance. We saw that after the initial boom, we started to give more blood. So you have to refine the protocols, you have to assess the protocol, you have to see the nuances and so on and so forth. So it's a lot of work. And I think that not doing it today is a testament of some type of, I wouldn't say don't care, but it's just not giving it the appropriate time and attention it needs to have by all of us.
Great stuff. There's a lot of questions coming in here. I'm going to paraphrase one from our colleague from Greece, talking about culture. So maybe, Ron, I'll start with you a little bit in terms of how do we adapt these protocols? So all your centers are obviously clearly well ensconced and embraced this concept. So where do teams start, and how do we adapt the concepts of ERAS for local culture? Do we suggest like starting and recording and adapting a culture and so forth? So let's start with you, Ron, and then we'll go to our other panelists as well.
So that's a good question. It's a very realistic question. If you're starting an ERAS program, I would base it on, you can look at our initial set of guidelines from 2019 and then our more recent guidelines. But you can't just start all the elements at once. And you know your program better than anyone. So what you want to do is look where the most unmet need is, but also where you have a chance for success, where you're not going to hit the biggest barriers. And we started our program at University of Maryland with six bundles of care. That was our initial ERAS program. We saw a great benefit from that. So you could pick 4 and just get people on board, and then you just keep building from there.
So, Dr. Fernando, Chris, you've also talked a lot about on the thoracic side, and you had very specific data points that you chose. How did you as a team decide these are the things that we want to measure, and how important was that to getting your team started in developing a culture around this?
So I think it goes to also to what Niv was saying is creating your team and then meeting and looking at what's happening and then revisiting what you're doing and then trying to see, are you meeting the metrics that you feel are important? And are you achieving those metrics? And then what can you do to improve on them? And then also revisit that from time to time, because there's an element of sort of forgetting about things and you know, especially say on the floors, you'll see nursing turnover, you'll see management turnover, and you'll see that people will come from a different background, and they'll be looking after your patients and not be aware of what you're doing, and you have to just keep on revisiting that. And you know, I've seen that a little bit in changing institutions where, you know, I don't have the benefit of an ICU, an operating room, and a PACU all on the same floor and a small group of nurses. In one of the institutions I have, we don't have thoracic anesthesia, and in another one we have thoracic anesthesia from time to time. So simple things like, you know, we don't want to use an A-line. Most thoracic surgeons are not using A-lines for lung resections now. Trying to bring Exparel into an institution for postoperative pain is challenges everywhere you go. So you have to decide what is the most important components, provide data to the folks that this works, either your own data like I showed, or data from other places, and show consensus statements, and just try and educate folks and keep working at it again.
Perfect. So Niv, along the same lines then, so with your rabbit pathway, how have you fed back this information to the progress that you've made to your teams compared to what you were doing before? Because I suspect that the data you're showing is compared to the previous way you've done business. Tell us a little bit about how you've ingrained that culture with your rabbit pathway and getting people to go through this idea of being heretically discharging people day one, day two. And then the second question to come up from one of our colleagues here is, how have you followed these patients differently upon discharge if you're discharging them so early?
Yeah. So the first part of the question, the answer will surprise most of you. So I chose a more aggressive way to force the issue when we started. If you say aggressive, I don't know, you may call it differently. And I convinced the board of directors of the hospital that in our board of directors meeting every quarter, the dashboard for quality, as you know, as the multidisciplinary team, quality and safety team, is going to be presented and followed like any other financial dashboard or any other dashboard in the hospital, in the Heart Institute. So what happened is that we forced the team to work together towards those dashboards and basically make sure that it's being implemented across the service line, because we have to report our outcomes. So like Ron, we didn't choose all outcomes to begin with. We chose, the first one was transfusion, the second was postoperative AFib, third one was extubation time, and the fourth one was readmission. And we grew from there on the dashboard. So I think we created kind of a commitment, if you may, to the higher level of the hospital to report on those outcomes. So we made outcome as part of the overall assessment of the performance of the institution. What was the second part of the question?
About how you may follow these patients differently with the early discharge.
Yeah, so we always followed the patient before we started all that with a phone call from a nurse that was in charge of all discharge patient phone call way back, and I'm talking about 2007. So a nurse would call all the patients day after, and then day 3 and day 6. All the patients, at least on my service, got a 1-800 number and an email address, so they could communicate if they were off hours, or they needed to leave us a message, and so on and so forth. But we didn't really follow them, like we are afraid. We were confident everything is okay. We may have been stupid, but we were confident it's okay. And really, we didn't have any bad outcomes, knock on wood.
Dan, I see your hand up. Please jump in.
Yeah, I think these are all great things. Couple take-home messages from what Niv and Ron have said. One is, don't try to do everything at once. You'll overwhelm the system. Pick one or two low-hanging fruit. Maybe transfusion and readmissions, and maybe early follow-up or institution of a multimodal pain strategy, something like that. And you need a dashboard. And why do you need a dashboard? One is you have no idea if you're successful, but two is intrinsically the competition alone will get people engaged and will improve everybody. No one wants to be an outlier. If 3 of the 4 surgeons are crushing it with green dots and one is in the red doing nothing, they will immediately get engaged and say, I don't want to be an outlier. What is this all about? Teach me. And it'll raise everybody up to the same level. Ron.
Yeah, great point, Dan. Another point that I learned, we all kind of know this, but I learned this really from Gina McConnell at Wake Med, is once you're doing ERAS, you realize it's really the nurses and your APPs and your physical therapists. We are not really doing anything. We're kind of participants and endorsing it.
We're
But
facilitators. I 100% agree with you.
and
Yep.
Gina told me the way you make your program successful is you go back, which is you really have to do intentionally. Go back to the nurses on the floor and in the units and in the OR, and you show them the results. You show them how the way they've changed what they're doing is getting patients recovered more quickly. And it's so motivating to the program that that changes the culture regarding ERAS.
Dr. Abbas?
Yes, thank you. I totally agree. And really, to jump off those last points, having implemented ERAS at different institutions, ERAS is one of the hardest things to do right. I think, like Dr. Ad said, all of us think we're doing enhanced recovery, but are we truly doing it without the metrics? This is an area where there are several key players, the nursing, but also legal and executive leadership. And unless you really have done your work and educated and gone back to them, but also had support from the top leadership, this is going to fail with a death of 1,000 cuts. So, really, really important to pick your team properly at first, a small group, and then expand it, like was mentioned.
Fantastic. So, Neb, I see your hand up. We have a couple of rapid fire questions I want to fire around everybody. Then we should summarize really
Just
briefly.
quick. I agree with Ron that it's being driven by nurses and mid-levels, if you may. But for instance, one point about our blood transfusion, you have to own it as a surgeon. And in our program, only a heart surgeon, cardiac surgeon, can allow a patient to be transfused. So whatever it is, you still have to have close monitoring of your programs.
Perfect. Thank you. No, agree with monitoring is critical. Feedback and summary to your team to get the whole team and continue to be engaged. Okay, quick rapid fire ones. Nib, let's start with you. When do you start amiodarone? Which dose and how much time? Was a question we have from Dr. Lopes.
Yeah. So we start amiodarone as soon as we can. So 5 to 3 days before surgery, 200 milligrams twice a day. If patients have heart rate below 50 or some other contraindication, they're not getting it. And we continue PO amiodarone 200 twice a day after surgery, and from day 3, 200 once a day for 8 days.
Fantastic. Ron, cell savers. How do you use it in your minimally invasive cases? Some of the time, all the time, none of the time?
I use Cell Saver in every case. I think the data is strong that it helps you transfuse less.
Yeah.
Okay. This is probably not a quick one, but we'll put it in the chat box there for both Christian, for Dan. How do we get residents training in ERAS? That's a good one. I haven't seen that question before. That's a good
It's
question.
our problem. We have to
Yeah.
engage the society level and give them some didactics. And also short form educational development where people can do it on their own time instead of reading a book, watch a video and take some questions.
I think it's holding them accountable to some of the protocols as well, and having them chart in the medical records things like, okay, what was the IS that they achieved, instead of having the incentive spirometer at the end of the bed in its plastic wrapper and not opened, and then showing by example when you make rounds and asking the patient to get up and asking them how many laps they walked, and just keep on having those conversations with the residents.
Fantastic. We're just about the hour. Let me turn it back to Dr. Dahl and Stan Elgers to sum us up for the end of the session.
Yes.
Go ahead, Dr. Dahl. My apologies.
Yeah, I think it has been a great session, and I hope we can continue the collaboration between ISMICS and ERAS, because it's so important. And also bring me up, Dr. Bonaros also mentioned that what about the benefit of ERAS in high risk and multimorbid patients? That is also a good question, because we now started the frailty scores in different all kind of surgeries.
And thank you. And as was stated earlier in the webinar and on the promotions, this is an accredited webinar. The information is being presented right now. There will be a link on the upcoming slide, which will be circulated to all the attendees via email. It's this link at the bottom of the slide you're presently seeing. Again, that link will be circulated for you to claim your CME credits for today's webinar. And this is a promotion for the upcoming ISMICS annual meeting in Miami at the Fontainebleau. Please join us. This is going to be a very, very good one, as always, for ISMICS. 10 to 13 June 2026, the Fontainebleau, Miami Beach, Miami, Florida. And the ismix.org website will direct you to the registration and other information on the program. Thank you very much.
Thank you, everyone. Fantastic session. Have a great day, everyone.
Thank you.
Thank you.